Good afternoon, everybody. For those who don't know me, my name is Leo. I'm one of the directors here at INNEG, and we have been running now for quite a while this fantastic series of webinars, particularly across 2024 and 2025, focusing on all areas of personal injury and clinical negligence, bringing you information from the experts who provide the reports and hopefully teaching us a few things along the way. For those who don't know INNEG, I want to just highlight our new branding and fantastic new website, which you may or may not have seen just yet, where there is some incredibly interesting pages focusing on the different specialist areas of experts that we require in our industry. And we do have a specific page on birth and pediatrics, both of which you can, in your own time at any point, go on to and actually see the numbers of different consultants that we hold within different disciplines prior to reaching out to us, should you require an expert in a particular area. For the record, we don't just list consultants on a database, we actually know every single consultant's specialist areas, which allows us to much better and far quicker match the appropriate expert to the appropriate claim. So with that, I know you don't want to hear about me. Let me introduce Dr. Phelan. We're delighted to welcome Dr. Phelan to today. She is a consultant obstetrician and gynaecologist at Imperial, where she's practiced for more than 30 years. She speaks and specializes on high-risk obstetrics, intrapartum care, maternity governance, and currently leads on CTG training and interpretation for her trust. So alongside her clinical work, she's also a very well-known expert witness, has been doing this for quite a number of years and is trusted by solicitors on both the claimant and the defendant side. She's outside of that held a number of senior leadership roles at Imperial and is recognized nationally for her expertise in root cause analysis, human factors, and decision-making in obstetric emergencies. So, without further ado, Dr. Phelan, thank you very much for joining us today, and I will pass the mic to yourself.
Thank you very much, Leo, and I'm delighted to be here today to speak to you all. You've already introduced and given a potted history of my areas of expertise in maternity, but I've worked in maternity for 32 years now. I'm still passionate about it, but there's so much to learn. So every 4 minutes, a woman dies globally of obstetric hemorrhage. It's a huge obstetric risk, and by the end of this webinar, about 12 women will have died. Does obstetric risk translate into medical negligence risk? Well, no, it doesn't really. They're two isolated entities. Hemorrhage is relatively common. I see it every day on the labour ward. It's fairly predictable and preventable. It represents a major risk of death globally and in the UK. But it's very underrepresented in medico-legal cases unless a hysterectomy is involved. This compares with severe acute intrapartum hypoxia, which is relatively rare. It's only about 1.5 per 1,000 babies. It's sometimes unpredictable. It's not a major obstetric risk, but it's overrepresented in legal cases because of the ultimate cause of cerebral palsy, which these claims run into millions, as I'm sure you're all aware. We keep getting it wrong in maternity. It's not rocket science, it's a physiological process, birth. So why is it so hard to get perfect outcomes and to avoid these claims? I like to consider 4 areas, I call them the 4 C's, when I'm interpreting problems, claims in maternity, because they all play really important factors in poor outcomes. They're choice, maternal choice, context, consent, and continuity. And I'll just take each one of these on their own. So choice was a concept that was really promoted by Baroness Cumberledge in the report that she authored, Changing Childbirths, in 1993. And at the time, it was quite revolutionary. And the report focused on empowering women and their caregivers to decide on the place of birth and how they would like their birth to go. And I don't think anybody that read that report wasn't supportive of maternal choice. The problem we've got with choice in maternity is that choice is absolutely wonderful when things are normal and physiological. Where we come unstuck is where women, patients make choices when the situation is pathological, because that's where the claims arise. There's lots of analogies to the airline industry in maternity, which I generally find quite annoying because they're not often analogous. But one thing that we can compare to is the airline industry with choice. It's a bit like when you go into a plane and you choose your seat, 1D or 11A, as I'm sure lots of people are choosing now. Airline industries promote choice. They expect you to choose your seat and they're very comfortable with you doing so. Where they're not so comfortable is if you choose your seat and then you refuse to put your seatbelt on. They won't let you take off. In maternity, women will choose their seat and they'll also choose not to wear their seatbelt, and we still have to fly the plane. And then when we hit turbulence and there's a head injury, somehow they will take it back and say, well, you should have insisted I wore the seatbelt. So you can see that choice can have negative connotations when things become pathological. At the moment in maternity, we're really in the spotlight. I'm sure you're all aware of the Morecambe Bay and Ockenden reports. Every unit in the country is under scrutiny. And because of the media hype, women nationally have lost trust in maternity services. And more, they're declining intervention because they've lost trust in the caregivers and they're concerned that they will have worse outcomes if they take the advice of the people looking after them. This has become so prevalent that my own trust, we've set up a weekly out of guidance declining intervention meeting to discuss women and the implications for them declining the advice that we're giving them. The human factors involved in declining intervention when situations are pathological are absolutely enormous, and that then contributes to worsening outcomes. The other C is context. Context is so important in maternity claims because labour is a very dynamic process, and very rapidly a low risk physiological labour can progress hours, minutes and seconds into a pathological process. Where the boundaries blur from this change from physiological to pathological is where the context is lost. Every risk report or MNSI report in the country talks about maintaining a global helicopter view of women's labour so that we keep interpreting what's happening in context. The trouble with achieving that, of course, is that more and more we have reduction in midwifery staffing. We're 2,500 midwives short nationally. And that means that the coordinator who's supposed to maintain that contextualised helicopter view is so busy providing care themselves that they can't maintain that context. Also, women's answer to a distrust in the service is to escalate to a consultant at all times. And the traditional role of the consultant as somebody maintaining a global perspective and not being knee-deep in the clinical care has now been lost as more consultants are having to do frontline work rather than give a contextualised opinion. The other C that affects maternity claims, and it's really crucial, this one, is consent. I'm often asked, has a patient, or often asked in allegations of breach, was consent fully informed? Well, I'll be honest and say after 32 years as a doctor, I don't know what that means. And what I mean by that is that the information that I give women when I consent them has no way of telling me, are they understanding, comprehending, and really understanding the nuanced consent that I'm giving them? And at no point in the consent process do we actually check that the consent that we think we're giving has been fully understood. So fully informed consent, the way it currently sits nationally, is something that I don't think is achievable. The other interesting thing about maternity claims is we never sit down with a woman at the start of her pregnancy journey and consent her for a normal vaginal birth, even though we know it's fraught with complications, tears, incontinence, bleeding, but we never talk to women about those risks. It's assumed that they would consent for a vaginal birth, even though they never have been. We know from the available studies that even when you take consent in advance, in the cold light of day, only 50 to 70% of patients have a good understanding of their situation. In obstetrics, situations happen so acutely that you're running down the corridor with the brakes off the bed, trying to achieve a decision delivery interval of 30 minutes. You can't give and receive consent in those situations. And so even though we are all trained to give a standard patter verbally, the women are so traumatized and stressed and often in pain that they don't understand or recall anything that you're saying to them. I don't do private obstetrics at the moment, but when I used to, I would sit down and consent women at 34 weeks for every possible eventuality that could occur to them. But even with that, consent does have to be more nuanced when you're actually in the throes of the clinical situation. So despite consenting for everything, I would still have to revisit some aspects of consent acutely to nuance it. The documentation of consent, of course, in an emergency, the doctors and the midwives aren't documenting what they're doing. And so the weaknesses in legal cases regarding consent are because the team is busy with the clinical care. And that's usually what lets us down, because the details of the consent aren't documented and aren't remembered by the patient. And underpinning consent is trust, and that just brings me on to the next C, which is continuity. Continuity of care, one-to-one care with midwives, continuity of care with clinicians or consultants is a dream in the NHS that we've never achieved. Currently, women, we talk about one-to-one care, one midwife to one woman, but of course, obstetrics is the only specialty in the hospital where you've got one clinician looking after two patients, the mother and the baby, at the same time. And in reality, often midwives will be looking after 1, 2, and 3 women in labour. So that's 1-to-6 care. There's no one-to-one care at all. A professor colleague of mine presented a survey at the Royal Society of Medicine a few years ago, and they surveyed the number of healthcare professionals a woman encountered during their antenatal journey. It was 47. How do you trust 47 different people? When you're seeing 47 different people, of course, they're all going to have a slightly different opinion. Which opinion do you take? Which do you trust? The ideal model of care would be to see the same clinician all the way through, but it's not a model of care that the NHS can provide. And the midwives that like to do caseloading, one-to-one care, get to know the women, provide continuity, have to be on call for those women. It's antisocial hours, long hours, and because of that, not many of the midwives want to do it. And midwives that then have families and other lives, work-life balance, then burn out quickly and stop doing it. So continuity is a real challenge, and it underpins the problems with the consent process. So there are key decision points during labour and delivery that carry the highest medico-legal risk. Place of delivery, women delivering at home or in a birth centre who would be best placed to deliver at hospitals with poorer outcomes often lead to claims. There are lots of claims centred on vaginal instrumental delivery versus C-section and consent around that. Of course, we all know about the monitoring issues, the CTG interpretation and lack of escalation leading to claims. From my point of view, the two big red flags are meconium and oxytocin. In combination, the outcomes for those two things together, leading to meconium aspiration syndrome, are real red flags, and very difficult to defend claims involving those two things at the same time with an abnormal CTG. And those two red flags have been present for the 32 years that I've been practicing. So let's focus in a little bit about common breach issues regarding CTG interpretation. And if we look at the 10 years of maternity claims report, it focused on the themes of misinterpretation of CTGs. So we've got failure to recognise an abnormal CTG, failure to act, failure to refer, failure to adequately monitor, and inappropriate use of oxytocin or syntocinon. Why are we so poor at it, you might ask? And I would argue and answer that by saying we're not. It's just that the CTG is a very poor tool to diagnose fetal hypoxia, but it's all we've got to go on. It's a very poor tool because it's got a high false positive rate leading to over intervention. And also it's open to a lot of subjective interpretation. We've got 3 national guidelines currently in use in the UK for interpreting CTGs: NICE, Physiological, and FIGO. And these are all not based on purely scientific evidence. A lot of the CTG guidelines are based on consensus with a bunch of experts in a room over a cup of tea deciding what should and shouldn't be the norm. So we've got a poor tool, we've got 3 different guidelines to interpret it, and we've got consensus rather than scientific evidence. So it's no wonder that we get it wrong. We've got computerized CTGs, which are in operation, but again, their studies have shown that they're probably only as good as a consultant. And the thing that computerized CTG, of course, doesn't have, which is crucial for negligence claims, is the ability to contextualize. And I would argue that the CTG is a poor relation to contextualization in intrapartum. And the more senior and experienced the clinician, the more their ability to contextualize appropriately. We spend a lot of our time in the grey area because we've got a poor tool that's subjectively interpreted. And I mean, I'm currently doing a case at the moment where the obstetric expert, the midwifery expert, the MNSI expert panel, and the trust own internal review interpreted the same CTG differently. And that just shows you how difficult these things can be. So we're in the grey area a lot of the time. And in the grey area, it's context that saves the day. Most clinicians, midwives and obstetricians, are good at diagnosing a pathological CTG. We rarely get that one completely wrong. And of course, once you diagnose a pathological CTG, you've got 30 minutes to effect delivery, and that's the gold standard that we've set. So the downside of missing a pathological CTG and the downside of not delivering within the 30-minute window is the risk of hypoxic-ischaemic encephalopathy and cerebral palsy. There are 2 classical patterns of brain damage seen after birth asphyxia. There's the brain damage caused by chronic partial hypoxic-ischemic insults, and this would be typical of umbilical cord compression with uterine contractions. And then there's a brain damage caused by an acute near total hypoxic insult, acute fetal bradycardia, cord prolapse, uterine rupture, placental abruption. And when we look at the significance of what it means when these insults occurs, we know from animal studies, and it's a generally held view translated from that an acute near hypoxic total insult of sufficient severity becomes brain damaging in terms of structural damage after about 10 minutes, and that fetuses can endure insults of 25 minutes or longer before they demise. So and if we look at areas of the timings nearer the 10-minute window versus the 25-minute window are associated with less risk of HIE and deep grey matter structures alone to be damaged. Longer insults extending into the periatlantic white matter, and they can involve the hippocampal formations, and these are associated with more damaging long-term outcomes of cerebral palsy. Minutes absolutely matter, and it's interesting to note that our guidelines set at 30 minutes, within 30 minutes for a pathological CTG. You could have a woman with a ruptured uterus of prolonged fetal bradycardia. You could deliver at 29 minutes, the baby would either die or be severely brain damaged, and yet you wouldn't have breached in your duty of care in achieving that. Governance and human factors do play roles in systemic failures in maternity care. Clinical governance with the traditional 7 pillars and human factors are key. And the main clinical governance that I would like to just mention is risk management and patient safety investigations. And I include MNSI and HSIP investigations in that. I'm afraid those risk management processes have failed in maternity, and in 32 years of being involved in patient safety investigations and root cause analysis, we are still making the same mistakes and finding the same investigation findings today as we did 32 years ago. And the reason for that is that we don't need to do any more investigations in maternity. We're doing national ones all the time at the moment. What we need to do is have a separate systems change team, because we've learned all the lessons. We know the same things keep happening, but we haven't invested in a lateral thinking systems change team to introduce national changes to all hospitals in the country that would reduce the recurrence of these incidents occurring. Human factors play an important role, and human factors are always influenced by the poor staffing, because when staffing numbers are reduced, errors go up, staff burnout and stress levels are higher. But the main human factors that we find in safety investigations in our own trusts and MNSI find is the lack of oversight of context, which I've touched on earlier regarding midwifery coordinators and consultants are losing their ability to contextualize because they're too involved in the care. You would think that a consultant being present more on a labour ward would improve outcomes. Well, we tried that, and Henderson et al. Published in 2017 the results of having consultants resident on the labour ward, and actually didn't make any difference to the outcome, because a standalone consultant coming in from home at 2 a.m. to diagnose a pathological CTG and to say that a woman needs delivery by a Cat-1 caesarean section is hopeless without the team to open the theatre, to staff the theatre, the midwife to catch the baby, the anaesthetist to anaesthetise. So consultants per se make no difference on their own. So, as I mentioned, we are in a grey zone for most of the time, looking at cases on the labour ward and cases where negligence is challenged. Most of the claims that I see in my practice focus on should have delivered earlier by C-section, wasn't consented appropriately for an instrumental, and failure to escalate the CTG in a timely manner to effect earlier delivery. Let's have a look at a couple of case examples that I've done over the past few years. I'll just touch on the first one, and these were regarding allegations of breach related to earlier delivery by C-section. So this was a woman in her first pregnancy with a morbidly obese BMI of 51. I think she was 120 kilos. And she was committed to a vaginal birth in her birth plan. At around 38 weeks, she developed a bit of blood pressure and a large baby. Induction of labour was suggested and agreed. And if you look on the NHS website, induction of labour is advised that it takes between 3 and 5 days. She had her initial induction pessary, which lasted for 24 hours. And after 24 hours, she wasn't contracting. She was getting fed up. The consultant came to do a ward round and made a plan to give her further induction agents. But the woman was sleeping, so the consultant didn't wake her and made a plan with a midwife. When the claimant woke up, the Prostin additional pessary was given, but the woman was still unsure whether she wanted to continue with the induction process. By 8 o'clock in the evening, she wasn't in labour and she was fed up and requested a C-section. The team were busy with emergencies on labour ward, so didn't review her. She laboured then rapidly overnight, and when she got to fully dilated, CTG concerns were raised, and she was taken to theatre for a trial of instrumental, to which she consented and had a forceps delivery, and then sustained a 4th degree tear, which is a recognised risk of that procedure. The allegations of breach related to she should have been counselled by the consultant on the ward round and woken up, and she should have had a C-section at 8 p.m. The allegations of counselling by the consultant on the ward round were denied because the midwife was able to do that appropriately. And the allegations of C-sections at 8 p.m, that was also denied because often it's not appreciated that if a C-section is not an emergency and people request it, it's not that clinicians decline to do the C-section, it's just not appropriate to do it out of hours. She had not been starved, she'd had an evening meal, so she wasn't starved for a non-emergency procedure. CPOD, a national advisory body, recommends that for all elective procedures, we should not be doing them overnight and should be doing them during daylight hours when there are more team members around. The acuity of the labour ward was so high that night that both theatres were in operation, so she didn't have a theatre to be operated on anyway. And also, where there's patient-specific risks that made her a higher surgical and anaesthetic risk, well, yes, with a BMI of 51, it wasn't safe for her to do overnight in case she had an anaesthetic complication and a failed intubation. So even had she been reviewed at 8 o'clock at night, the team on balance would have decided to do her the following morning. She would have laboured overnight in any event. And as she did consent for an instrumental, on balance, she would have ended up with the same injury and it wouldn't have been avoided. Case example 2 is regarding consent for an instrumental delivery. This was a sad case of a 42-year-old woman who'd had 13 years of failed IVF and then finally conceived. She had gestational diabetes. She was offered a C-section antenatally because her circumstances were considered high risk. However, she declined. She laboured to fully dilated. CTG was suspicious. The consultant reviewed and took her to theatre for a trial. They attempted a von twos with 3 pulls and it failed. They tried to put the forceps on, they didn't lock and so abandoned. She ended up with a C-section and the baby had a massive intracranial bleed secondary to the von twos and died at 20 minutes of age. Breach related to failure to do an elective C-section, it was denied because the documentation regarding her antenatal discussion was good. There was breach related to failure to consent for forceps. This was accepted, but causation was weak because the post-mortem revealed that the bleed was secondary to the von twos and the forceps weren't used in any event, and so the causation was weak. Case example 3, failure to escalate a CTG. This was a woman in her 4th pregnancy who ruptured her membranes at 25 weeks, and she went to another hospital because of her gestation until 32 weeks, and then she came back to the mother unit. A plan was made for her to be delivered by elective C-section at 36 weeks. She came in at 35 weeks and 5 days, so 2 days before her planned C-section tightening. So she was high risk of labouring quickly. The CTG on the top was classified as normal. It wasn't normal, it was suspicious. It had decelerations in it, which you can see at the top CTG. They discontinued the CTG because they thought it was normal. And then they came back an hour and a half later because she was in increasing pain and tried to pick up the fetal heart. And you can see from the bottom CTG that there is clearly a difference. The baseline for the top one is around 150. The baseline from the bottom is around 100. This was the mother's pulse. The baby had already died. And there were breaches, allegations of breach related to failure to classify the CTG initially as suspicious, and that was accepted. Failure to escalate for an earlier C-section because on balance the CTG would have deteriorated, and this was accepted. And so that case, the allegations of breach for that case were accepted. So this 4th example just really focuses on human factors and how they can contribute to poor outcomes. And human factors are really important. And I've seen quite a few negligence cases where staff have been looking after staff friends And we can see a lot of that in midwifery, because lots of midwives who train with other midwives will ask them to look after them. And so the human factors in friends looking after friends is enormous. So this woman was a 33-year-old midwife. So second baby, a first baby delivered rapidly, normally. So she was on balance going to have a second rapid normal birth. So she booked for a home birth, and she was looked after by her 2 midwifery colleagues and friends. In the pregnancy, the midwife developed symptoms of a urinary tract infection, and doctors and midwives are notoriously bad at trying to wing the system. So she sent her own urine sample without telling anyone, and it came back positive for group B streptococcus, which you may know requires treatment intrapartum to protect babies from a 1 in 700 risk of group B strep sepsis. The midwife didn't disclose her result to her midwifery team, and she decided not to have treatment, and nobody knew about the result. She went into spontaneous labour at home. After 24 hours of rupturing her membranes, she still hadn't delivered. So the midwifery colleagues advised her to go into hospital to be augmented, which she declined. And the midwifery colleagues weren't really forceful in their advice, because they wanted their friend to have a home birth, which was her dream. At 8 centimetres, they examined her and they diagnosed breech presentation, which was undiagnosed at the time. Transferred her to hospital via ambulance. The breech was advancing and she had a vaginal breech delivery, and sadly the baby died of overwhelming group B strep sepsis. So the allegations of breech related to the midwives didn't check the abnormal urine result. That was accepted because all results should be checked during pregnancy and before labour. It was a breach that she wasn't counselled regarding the group B strep result that should have been identified, and that was also accepted. There was a breach that the breach was not diagnosed sooner. That was denied, because we all know that we can miss breech deliveries, as women don't routinely have a scan before labour. And it was a breach that she did not have a C-section on arrival to labour ward, and that was denied because the breach was imminently going to deliver and it wouldn't have been safe to proceed to C-section. Causation in this case was denied, as the group B strep treatment, even had she been counselled, would on balance have been declined in any event, because the mother was committed to not having treatment for group B strep intrapartum. So in my experience of obstetrics, delivering earlier by C-section is a common theme in litigation cases, but in my experience of women, if they don't mention it in their birth plan from the beginning, they usually are not committed to having a C-section at any point in the labour, unless it's for fetal reasons, and they want to continue on a path of a normal delivery. If women do request a C-section at any point, antenatally or intrapartum, we always say yes. We never, I've never in my 32 years said no, and I'm not aware of anybody else has in my trust. However, it is our job as obstetricians to contextualise their choice. So if a woman is asking for a C-section at fully dilated with the head very low down in the pelvis, you're duty bound to explain that actually the risks of an entrapped, stuck head at C-section could be far more dangerous for the mother and the baby than an instrumental delivery at that time. So whilst we support choice fully, you do have to contextualise women's request in light of the risk and of her clinical situation. Consent for instrumental delivery features so highly in legal claims, and documentation, as I've explained, is poor because the team are busy delivering care rather than writing notes. For a long time in my trust, I've emphasised that the only way forward, I think, in this culture of she said, he said, and there's always a mismatch between what women remember and what doctors say they said, I think we have to have body cams, because if we could record the information that's being said, then at least that would be something. Women in general don't recall what's being told to them acutely for a Cat 1 section. And I do a debrief clinic every week where women have had traumatized by Cat-1 sections and they never recall the consent process. So it's a complete waste of time the way we're currently doing it, but it features highly in claims. Failure to escalate CTGs in a timely manner. As I've said, a pathological trace is rarely missed by staff, but because it's easy to diagnose it, it's the suspicious CTGs that are the grey zone. And it's quite easy to defend a claim with a suspicious CTG if the context is normal. But if you've got a clinically concerning context, then suspicious CTGs can't be defended. And this is where the helicopter view and the consultant view globally comes into place, because context changes very quickly with suspicious CTGs. So unless you're really clinically looking at the bigger picture, you're going to be on a sticky wicket when it comes to defending these claims. So, in summary of obstetric claims related to brain injury and stillbirth and neonatal death, there's a potential for breach of duty of care if the clinical risk factors weren't appreciated or acted upon by the team. It's very difficult to defend these claims. If there was a clear misinterpretation of a CTG or a failure to escalate concern, then you can't really defend these claims either. Where there's limited causation related to if earlier escalation wouldn't reasonably have changed the delivery timing or outcome, and if a consultant attendance from home would not have materially altered the management, then that's limited in terms of causation. And where instrumental delivery was clinically appropriate and consent discussions reflected that plan, again, these causation would be limited. And so I think it's really important that whenever you're looking at or involved in giving expert witness views for these claims, that it's the clinical context more than the CTG that is whether it's going to decide on whether you can defend the claim or not. Thank you.
Thank you very much. Thank you very much, Dr. Phelan. That was really very, very interesting. I think on behalf of everyone, I can say thank you for the insight into your practice and obviously this care. I forgot to mention at the beginning for everyone viewing, but obviously Dr. Phelan is more than happy to answer a number of questions now, if anyone has any. If you can pop them into the Q&A function or the chat function above. But myself, I was just listening to that and I wanted to ask, you suggested that new technologies such as body cams would help. But I was going to say, would that allow more defensibility, or would that add new risks and potential claims from the claimant's perspective, or would that help overall? As in, would it improve it or not? How would that actually work from a litigation perspective?
Well, I think in terms of what it's been, where recordings and cameras have been used in the States, and certainly with the police in general, the footage has been supportive of the doctors and the police officers in terms of recording that what they actually said they did. So I think that's where it's going to be powerful. You know, lots of claims relate to women saying the doctor never mentioned that risk to me. And so where you have the ability to play the recording that they did mention it, then I think that would be helpful. But fundamentally, as I mentioned before, you know, consent in obstetrics is deficient, and a move to consent women for everything at some point during the antenatal care would be a way forward. And on balance, that would lead to high numbers of women choosing to have elective C-section, which we're seeing anyway. I mean, the section rate in my unit's almost 50%, and that's because the more you tell women, the more frightened they become.
No, thank you for that. Couple of more questions here. We've got a question from Lindsay Furley, who's asked, can you please describe a pathological CTG appearance?
Yes, well, a pathological CTG, it's defined on the criteria from either NICE, FIGO, or physiological, but in general, it's it looks a bit like a flat biro line, just a flat line, or a line with lots of decelerations in it. And I'd have to show you pictures actually of pathological CTGs because they can be variable, but it's related to lack of accelerations, lack of variability, the flutter that you see on the normal CTG, decelerations, or profound fetal bradycardia. And those are the sort of 4 types of findings you'd see on the CTG. It's best represented pictorially. So if you want me to follow up with some pictures of classic pathological CTGs, I can.
Perhaps for a future presentation. Alison Brooks has asked if you can explain a little more about the lateral thinking and how this would work in practice to stop future mistakes. She paraphrases this with, "We also see the same errors from 30 years ago, and clients are desperate for improvements to be made." So what sort of lateral thinking could be used? How would it work?
Yeah, well, it's a bit like, Team GB cycling, that the team of experts that they got to improve the cycling performance included people all outside of the cycling industry. And, we're very close thinking in medicine, and in the NHS especially. So I'd want captains of industry, IT experts, people from, we've actually approached Google, people from Google and AI experts to help us, because we can't come up with the solutions in the NHS. That's why we're still making the same mistakes. So we'd need people out with the organisation to say, look, this is the systems change you need to effect. Because as I said, 32 years on, whenever I write a risk report, it's the same findings. It's because we don't have a team to advise us how to make the systems changes that we need.
Thank you. And we won't go into it, but I'm sure then there's the culture of whether those changes would be accepted or not, but perhaps a conversation for a different day. Melanie Isherwood has asked, first of all, she wanted to thank you for a very interesting session and wanted to ask, do you see litigation as a positive or a negative factor in improving patient safety within obstetrics?
Sorry, say that again, Leo, I didn't hear you. Do I see what?
Do you see litigation as a positive or negative factor in improving patient safety?
That's a really good question. I think it's a positive thing because it holds us accountable for errors that we make in a way that risk management investigations, patient safety investigations, MNSI, in my opinion, aren't helpful, and trusts don't take them seriously. If they did, then we wouldn't be where we are now, because the changes that you need to make to improve patient safety cost money, and trusts in general don't want to spend that money. And when I say it costs money, it's staffing, resources, and providing the sort of care that you need for women. So if we're not going to invest in the care that we know is suboptimal, then women deserve the right to take legal action and to be compensated for poor care, because I know that changes could be made, but the changes are expensive. And so, yes, I think it's a good thing that we're continually held accountable, because the trusts listen to legal claims because they're expensive.
I always think on that point, I always think it seems a bit crazy that obstetric related claims only equal about 12-13% of clinical negligence claims, yet are in the region of 2/3 of the cost. You'd think that the government could see that and would try to improve that proportionately. But again, for greater minds than ours in relation to funding. Lindsay Evans has asked, would more education about the risks involved in pregnancy and labour prenatally be helpful in managing consent in an emergency situation?
Yes, definitely. I mean, what I have suggested in my trust and what we're moving towards is that we consent all women antenatally for everything. And we also, in that, should include consent for vaginal birth, because 1 in 3 women in a first labour is going to end up with an instrumental delivery. And when you suggest an instrumental delivery to them in labour, they're horrified. 1 in 3 is a big risk. They need to know this information. And the current antenatal classes, I'll take the NCT, the National Childbirth Trust, for example, focus on normality. Well, you know, in my unit, 61% of women will end up with a normal birth, and the remainder don't. And we need to antenatally educate these women far more. It will lead to an increased C-section rate. I mean, that's why obstetricians who are fully informed have such a high C-section rate, because they choose it. So I think it will push the C-section rate up. But as women are limiting their families to 1 or 2 children in any event, it's not going to have big implications for long-term surgical morbidity, because women aren't having 5, 6, 7 sections. So
no, thank
yeah,
you.
I think it would be helpful to do that.
Is it okay to carry on with a couple more questions?
Yes.
Fabulous. I just know because there's quite a few here. Clearly touched a chord with people, and very interesting. Katrina Taylor has asked, why did the MW in your case study decline treatment for the GBS? It seems a little odd. And I know you don't want to go too much into the detail of a case that you've done, but the familiarity of the risks, why would she
Yeah, well, it's a very good question. And let me answer it by saying that, so group B strep is a bacteria that lives in 30% of women's vaginas. It's a commensal, just like your bugs in your nose or your throat, your bottom or whatever. And women it's got no implications for women. It doesn't cause any disease in them. And rather unfortunately, babies aren't immune to group B strep. So if they get exposed to it as they come through the pelvis in labour and they get infected, it can kill them. So it's a bit of a design fault of the system. But the government in the UK, unlike other countries, has decided that it's not worth screening, given the fact it's so common, it's not worth screening all of these women nationally at 36 weeks to see if they carry this bug, and then treating them with antibiotics in labour to protect the baby, because the cost-benefit equation doesn't work for them, in that you'd end up having to treat quite a few hundred women to stop one baby dying. And then of those few hundred women you're giving antibiotics to, some of those will have anaphylactic result to the antibiotics and collapse. There's all sorts of morbidity to going along with it. So the long and the short of it is, currently in this country, we don't screen women for a bug that we know a third of them have carry, and we know that 1 in 700 of those women that carry those bugs will have an infected baby. And so this midwife, who knows that information, thought, well, you know, people aren't even screening for it. There's loads of women who are currently labouring with ruptured membranes in this country as we speak, who've got group B strep that they don't even know about because we don't screen. In America, they screen. In Europe, they screen. In Australia, they screen. So she made quite a reasonable judgment, like the government has. It doesn't really matter if you've got it or not, because it doesn't really, it's not common enough a risk or high enough a risk that it's going to affect outcome. And she interpreted 1 in 700 as a small risk, which it is.
No, thank you. Avina Vasilenko has asked, when would be the latest time a woman can request a C-section if vaginal birth is not progressing?
Anytime. Anytime a woman requests it, as long as it's not more dangerous to, I mean, if it is more dangerous to do it, and like the head's kind of hanging out, you know, you've got to say, look, I can't do it. Because, you know, I've never been frightened during an instrumental vaginal delivery, but I have been frightened with a stuck head at C-section. It is the worst situation to be in obstetrically, because you've just got nowhere to go. You can't get the head out, and it's so traumatic for the womb and the baby when the head is stuck so low down in the pelvis you can't get it out. So if I really thought there was a risk of that, I would say to the woman, look, I don't think it's safe. I don't want to do it. I'm not going to do it. You know, it's not safe. But any other time, if a woman requests it, I do it.
Fabulous. No, thank you. And just to finish off with one last question, if I can, again from Lindsay Evans, what is your position on stillbirths being handled by the coroners?
Sorry, say that again.
What's your position on stillbirths being handled by coroners?
Yeah. Well, it's interesting because I'm the lead for the coroner's inquest at my trust, so I attend all of the inquests where there has been a stillbirth, and I think it's really helpful for the family. Actually, in my experience, because it ups the ante for the level of the investigation. They've got an independent coroner's perspective of it, and for the really sad families that have been through this horrendous experience, I think it gives them a level of independent investigation that enables them to gain more closure than having been handled by the hospital alone. So I welcome it, and I really welcome the importance that the trust put on the coroner's inquest and their findings. And it really does hold trusts accountable when the coroner makes their recommendations. So I think it's a really important thing.
Thank you very much. And I promise you now the last one, but we've just had a last minute question come in from Colette. And she said she may have missed the previous slide and the context because she joined a little late. But you mentioned that oxytocin was a red flag. Can I ask if you could clarify what you meant by this? And just before you answer that, for everyone still watching, the recording and the slides will be made available in the coming days. They will be emailed to you, so you'll have access and be able to review everything. But yes, oxytocin being a red flag, what's
Yeah, so oxytocin speeds up uterine contractions. Optimal contractions in normal labour is 3 to 4 every 10 minutes. So oxytocin should only be used to achieve 3 to 4 contractions every 10 minutes. However, seemingly this is impossible for us to achieve. And whenever oxytocin is used, about 15 to 20% of the time, the womb is overstimulated with contractions going 5 or 6 every 10 minutes. When that happens, every time there's a contraction, there's no blood flow to the baby. You overstimulate the womb, you reduce the blood supply to the baby, they become hypoxic. So it's the most dangerous drug we use on the labour ward, but it's also the most widely used. And you could make a reasonable case for banning its use altogether, because it leads to an increased risk of fetal distress, hypoxia, and if there's meconium present as well and the baby gasps, meconium aspiration syndrome. So it's a lethal drug on a labour ward.
So to be used very, very carefully, in your opinion.
Absolutely, yeah.
Well, look, we're getting a lot of thank yous coming in now as well. And I think on behalf of everyone, Dr. Phelan, I want to just again, thank you very much for your time. That was incredibly insightful. And to everyone here, thank you for joining us. And we look forward to seeing you at our next event. Thank you very much, everyone.